please stick around if you're able to. We're going to move along here to keep us on schedule. And we're going to ask Valentino Lozano, if you could maybe get your slides ready, who's going to speak a bit about the angle, gonioscopy, angle closure, talk about some of the technology, and I think will be relevant to all ophthalmologists as well as those that practice glaucoma. So Valentino, who's one of our fellows, as I mentioned earlier, who is originally from Chile and is trained at the University of Florida, also known as Gator Surgeon. We've got to change that because you're no longer from Florida anymore.
If you have any ideas, let me know.
Yes, we got to have another catchy name for you. So thanks a lot, Valentina.
All right, hi everyone. I would like to start this talk by asking the crowd, so you can write it on the chat. What do you think is Ike's favorite word? Oops, I missed it. Well, anyway, you already saw it. So narrow angles. Actually, it's not Ike's favorite word. I remember coming to this fellowship, and to be honest, I did use it. So when I came here, I realized that it was either angle close or angle open. And I hope with this talk, you're able to kind of have a better idea and understanding of how to describe those angles. And just so that you know, Ike's favorite word may or may not start with an F.
It's focus. It's focus in the OR. Focus and fulcrum.
Yeah, I missed it up. Okay, so case presentation here. We have a 65-year-old female referred for evaluation of narrow angle glaucoma with elevated IOPs. Her pressures right now are 18 and 19 on 1 to 2 classes. She's in tribatan in both eyes and ASAP on the left. Her Tmax is 23 on the right, 36 on the left. That was without medications. On exam, she was 20/20 in both eyes. We measure her pressures at 16 in both eyes, no efferent pupillary defect, and she had average central corneal thickness. On her prescription for glasses, she was a little bit of a hyperope, low hyperope. On anterior slit line exam, pretty unremarkable, except we noticed that her anterior chamber had a moderate depth in both eyes. She has trace nucleosclerotic cataract, and on gonioscopy, we noted a 270 degree iridotrabecular contact. So no peripheral anterior synechiae and 1+ pigmented trabecular meshwork. And I do want to say a few words on gonioscopy. I think gonioscopy, it's a very important skill, yet very underutilized. In fact, they did a study in the United States where they grabbed a few people from, well, hundreds of people from Medicare, and they did a retrospective study, and they showed that less than half of those patients who were diagnosed with open angle glaucoma had a gonioscopy exam 12 months before being diagnosed or even 6 months after. And then only 49% of patients who had glaucoma surgery, they did not have a gonioscopy exam 4 to 5 years before that. So I think it's quite impressive. And I do want to convince you in this talk, like why gonioscopy is really important to become familiar with. And I think the main reason why is that when we're practicing in residency, like we get so confused with like Spade, Schaefer's, Shea, there's so many numbers, letters, and I think it's very overwhelming. So I just want to make it very simple here. The definition of close angle is just, if you're looking at that and you're looking 2 quadrants and you don't see the trabecular meshwork, that's close angle. So pretty much here, 180 degrees or more of iridotrabecular contact. You're not seeing the trabecular meshwork. And there's a nice mnemonic here, you know, like it's called like, I can see this thing, where you can just remember the structures going posteriorly to anteriorly. And again, I do think that you have to turn the lights off. That's something that some people find that it's kind of slows down your practice, but you do have to, otherwise you'll have not an accurate result. But that 2 quadrants, you're not seeing TM, that's by definition close angle. As simple as that. You don't have to be doing any other gradient system if that really confuses you. And I would say for learning curve, I mean, remember those days when we couldn't even see the back of the eye with an indirect light? Like, I think it takes a little bit less, but you do have a learning curve. So I just encourage you to practice on all the patients, especially if you're trying to do MIGS, you know, any anterior segment surgery, glaucoma surgery, you need to know the angle status. Luckily now, apart from having gonioscopy, we're having new devices. So we do have the anterior segment OCT, which is kind of helping us identify the angle and help us see if this is open or close. It's pretty nice here. You can see how the anterior chamber. You can see the lens, the lens vault. This is the cornea. It shows you very nicely the iris along the iris root. And we're going to focus here on the scleral spur because we've been using the scleral spur a lot to as a parameter to see where the angle structures are. And Seeger et al. In 2014 came up with really 3 good techniques for identifying the scleral spur. And they mentioned that by using these 3 techniques, you can actually find the scleral spur in 98% of the cases. So one is the ciliary muscle. As you can see here, you can see the ciliary muscle has a different color from the sclera. If you just go all the way until the end, that would be where the scleral spur is. For the bump, you can notice where they say that the scleral spur has like an anterior projection to the anterior chamber, and that's the bump. And we'll show you some examples here. And the other one is the Schwalbe line, where you're looking at the end of the Schwalbe line, and then they say that if you go 1 millimeter more posteriorly, then you should be able to find the scleral spur. Now, cases for open angle, on the closed angle, you can see here in the open angle, once we zoom in, you can nicely see that kind of the bump that we were talking about before. That would be an open angle. And then here in closed angle, you can see how scleral spur is in contact with the iris. Now, what is also nice about the anterior segment is that you can actually see some findings of what's causing this angle closure. And I picked like really dramatic cases that just so you can see the difference. We have pupillary block here. You can see how the iris, instead of being flat, actually has this curve. So if you make a line from the iris root to the pupil, if it's not flat and you see this concave shape, then you should consider thinking, okay, this patient may be having some component of pupillary block. Then you have the lens rise, where you can see where the lens is just so fat that it's pushing the iris forward. Then on the top left, we have the peripheral anterior synechiae. And again, this is pretty dramatic. You will mostly see a little bit less, but you can see the iris tenting. So it just kind of changes the direction of the structure. And then the last one, which I do find a little bit more harder to know, but anterior segment OCT can also show you if there's a high iris insertion, so plateau iris. Maybe the anterior body of processes are more anteriorly positioned, and that's what's causing the angle to be closed. So if you start looking at these things, like, am I seeing lens rise? Am I seeing pupillary block? If not, then that kind of helps you to define what's causing this angle closure. Now, going back to our case, as you can see, it's not as bread and butter as the other ones, but we're gonna ask the panelists to just pretty much run by these, and what are your thoughts?
Maybe I can start here. So I'm trying to find my annotate button, but for some reason it's not showing up. Maybe I'm going to ask for your help here, Valentina, just to use your cursor. But I usually find that one important thing that I look for when I'm looking at anterior segment OCT is really determining where I think the scleral spur is. That being said, it can be challenging, especially in closed angles. So if we look at the right eye and we look at the leftmost angle, maybe Valentina, you can help me out here. I find this is kind of tough to determine where the scleral spur really is. I do think it's probably somewhere in that area. You can kind of use the Schwalbe line method here, because I think I can kind of visualize where that U shape is. And if you go about 1 millimeter back, then you would expect the scleral spur somewhere there. I would say it's a bit more anterior than that, Valentina. A touch more.
Do you have your annotation? Because Baby Boss is really good at describing these, and you really, like, if you want to show like the participants, like how to look for lens rise, like what are we looking at? That way, whenever they go home, they can practice.
The annotate button's not showing up, but it's honestly through Ike and Devesh, who's actually taught me this before as well. But Valentina, maybe you can draw the line for the scleral spur, which I think is another important thing. So from one end to the other, maybe you can just use your cursor. If you have your annotate button, maybe you can do that. Right now, I seem to be having trouble finding that.
Yeah, me too. I don't have an annotation. I used to have it. Well, anyway, yeah, so you want to point out that scleral spur. I mean, it's hard, right? It's not the bread and butter here. And I would say I can actually see it a little bit better on the left.
Can you kind of use the ciliary muscle method in that one, I find.
Right, exactly. So from here to here, all the way.
Yeah.
So there, yeah, the most I can find right now is the ciliary muscle method. Yep, exactly.
So by doing that.
Ike, do you have an annotation that you can?
Yeah,
here?
you know what? I think it's not coming on right now for some
Um,
reason. So
Yeah,
you have to use your mouse button. I think we can see your arrow though.
yeah,
yep,
but
yep.
Yeah.
So that's from
again,
scleral
Valentina.
spur to scleral spur.
So one thing that that shows you also is how much component of lens rise you're having. So if you're under 1/3 of your AC depth from the looking at the anterior surface of that lens, which in this case, I do think you're less than that, I worry less that there's a big lens rise component. I mean, there can be a little bit. And I would say maybe the curvature of this iris does have some concavity. So I do kind of wonder if there's a bit of pupillary block component here. Plateau, I don't necessarily feel comfortable determining just from this so far. I don't know what you think, Devesh.
Yeah, so I mean, this is a fantastic example. I mean, we often look at how to find scleral spur, and people show examples where it's really obvious. This is a real life example where, you know, when the angles are closed, I find that sometimes the hardest to pick out scleral spur because everything kind of blends together and looks the same white. But here, these to me, these look closed, and I agree with where you pointed out on the left eye, the leftmost side there. That's probably the easiest spot to find scleral spur. But knowing where it is there, you know, you can kind of deduce it for the same scan, left eye, the right side of that scan, and then you can kind of deduce that the right eye is totally closed. I agree that lens rise doesn't look to be a huge component here. Pupil block doesn't look to be a huge component here. And although, you know, it's not easy to image ciliary processes with an anterior sago CT, and this is a good example of where you can't really see it, I would probably say this looks like there's some significant plateau pushing that iris forward, particularly if you look at a left scan on the right side. You can kind of get a sense of this. So the left eye, eye scan and the right side of that image. So all the way to the, yeah, exactly. You can kind of get a sense that there's ciliary processes pushing up over there. So I would say, yeah, these angles are closed with plateau, a small amount of lens rise maybe, and a small amount of pupil block with primarily plateau.
I think that's an excellent description, and it took me a while to understand, but you can have a close angle with different, you know, it could be multifactorial. So yeah, great. And just to show you the pupillary block, like it's not much, but if you arc from the iris root, you go and make a line, you can see that it's somewhat curved. So perfect. Okay. Then, of course, this is why it's important to do gonioscopy. You know, you want to correlate to your gonioscopy exam. Like, is there any big fat cataract causing some lens rise? Do you see a double hump for plateau iris, or is there any broad or scatter PAS? So all those things. We do also have something really nice that it's the ultrasound biomicroscopy, which it can penetrate deeper through the tissue. So you can see here actually this big ciliary process on this area. And I
would add one thing here, Valentina, that the UBM is fantastic to confirm plateau, but not required necessarily. I think you said earlier, you want to correlate with gonioscopy and the double hump sign. So, you know, plateau iris syndrome, I guess, when it's causing you a problem, it's a clinical diagnosis. It's great to have the UBM, but not absolutely required. So for those of you who don't have access, don't worry, you can still diagnose this.
Right. But it's nice to see, you can see, like, I made a difference here, how the resolution, you know, I mean, it's better resolution in anterior segment OCT, but it can just penetrate deeper in the tissues. All right. For fundus examination on cup to disc ratio, we did notice some asymmetry, more cupped on the left and on the right, peripapillary atrophy with some inferior thinning on the left. Also, this patient had a little bit of RPE modeling in both eyes. Retina was flat, vitreous was clear. On the left, we have the RNFL analysis, and to the right, we have the ganglion cell layer. And as you can see here, we're just gonna focus, it was a good test. The RNFL thickness map, you can notice a big difference between the color map, you know, left thinner than the right. And then if we go here to the RNFL thickness, you can see the asymmetric difference between the right eye and the left eye, being the left eye more thin. And then on the ganglion cell analysis, we can see some ganglion cell loss on the left eye inferiorly. And this nicely correlates here to our visual fields. Again, accurate, reliable tests. On the right eye, we did see some non-specific deficits on the right, and on the left, we had an arcuate defect superiorly. Now, one last thing that I do want to explain to you too is that there's different terms for when you're looking at angle closure, and these are super important. So you have PAX, you have PAC, and you have PACG. PAX just means, is the angle open or closed, to what we talked about before? Are you not able to see the trabecular meshwork in 2 quadrants or more? And in these cases, the IOP has to be normal, and there has to be absence of peripheral anterior synechiae. Then you have PAC, which is primary angle closure, and basically it is an angle that you see close, but in these cases, you either have peripheral anterior synechiae or the pressure is high, above 21, and no optic nerve damage. So no visual field damage, no optic nerve damage. And then you have primary angle closure glaucoma, where you have closed angle, either high IOP or presence of anterior synechiae, but you also see optic nerve damage and a reproducible visual field defect. And one of the things that I like when people refer to us and they do give us the Tmax is that you can really make sure that this is packed, you know, because sometimes when you see the patient, they have a normal pressure. So you can categorize it as packs, you know, that's because they put them on drops. So it's really nice to have Tmax when we get referrals. Now for diagnosis, after all this, we have a 65-year-old female. We diagnosed her with primary angle closure on the right and mild primary angle closure glaucoma on the left. And again, just a reminder, pressures are 18 and 19 on 1 to 2 classes, Tmax 23 and 36. And our poll number 1 would be, what will you do next? Will you observe? And we can bring the poll at IOP, lowering meds, laser peripheral iridotomy, iridoplasty, or cataract surgery. Oh, you brought all of them.
Yeah, I think the way Jeb programmed them, they're all together. That's okay. I guess we'll have to have everyone answer maybe number 1.
Yeah, just answer number 1.
Yeah. Hopefully everyone can see the poll. Sometimes the polls don't. Okay, looks like some people are answering.
Can you see where I'm voting?
You know, it's not letting you answer only one question, it sounds like. So everybody has to answer all of them. So
oh no.
Sorry about that, everybody. But that's okay. Just go through it. Answer your first choice. Answer what would happen if you had to do something next. And if you had to do cataract surgery, would you combine it? So we'll answer all of them together.
That's cheating. Okay.
Sorry about that.
Thanks, baby boss.
Maybe we should clarify which for right or left eye, because I do think you could argue one versus the other.
Okay, let's focus on the left.
Okay.
Yeah, let's do the left. So mild primary angle closure glaucoma.
Okay, so I'm just going to end the poll here. We have almost a third of folks that have answered here or more, and we'll just share the results here. So you may want to maybe walk through it a little bit, Valentina.
Okay. 3/4 picked LPI. Great. Okay, awesome. What will the panelists do?
Do you want to start?
Sure, yeah. So I would start with an LPI. I mean, the anterior seg OCT did show a small amount of people block, and I think it's worth giving it a try as a first step. It may not be the only step, but certainly a first step.
Yeah, perfect. So we actually ended up doing that.
I'm just curious. So this is, you were talking about the left eye or right eye? Actually, or both eyes here?
Yeah, so the left to make it easier, but we actually did an LPI in both eyes. And actually this shows really nicely, though, especially on the left, you can see the curvature, like the concave curvature of the iris. Now it's flattened out. So we relieved the pupillary component of this patient, but we still thought that her angles were still closed.
I'm just wondering a couple of things. Number one, what do the panelists think about the Eagle study? Because this is basically a patient, right, Valentina, that basically kind of would be what would likely have been enrolled for the Eagle study, right? Yep. And maybe you could, maybe the panelists may want to, you know, talk about what kind of the Eagle study results were and why or why not we would maybe follow perhaps what the results were.
Yeah, so I would say that the left eye definitely fits within the criteria. It's a mild primary angle closure glaucoma case, clear lens in a patient who's above, I think was 50 years old. So I think in that case, you could make an argument for cataract extraction. The right eye, I mean, the issue there is that, yes, it's a PAC. The study did look at patients who had pressures above 30, though. In this case, it was never above that. And I think that's kind of an area where it's a bit unclear. You could, you know, kind of go with the LPI route first. I think in this case, you know, you could go LPI in the right eye and then while you're kind of setting up surgery for the left eye. But I think that's a bit of a gray zone, you know, based on, if we're looking at that study, I don't think it's clear what the answer is for patients with PAC with pressures under 30. So that's probably what I would do.
Yeah, the other difference between the Eagle study and a real life practice here is, in the Eagle study, if you were randomized to the PI group, then, and if that wasn't adequate to control your pressure, you got meds after. But in our case, if the PI is not effective, we can still choose to do lens-based surgery. That just wasn't the way the Eagle study was set up. So I think in real life, it makes sense for a low risk intervention to try the PI, and then if need be after, move on to lens-based surgery.
I think Devish makes a really, really good, valuable point, and I think, and that's why I think Valentino probably will speak to this about, you know, that the follow-up and the next steps are going to be important in terms of assessing that. There's a lot to dissect with the Eagle study, and I think it's true that although on the surface you look and you say, well, maybe a little less medication used, less patients required for their surgery, maybe some slight better quality of life. When you do phaco versus doing an LPI as initial therapy for angle closure over 30 or angle closure glaucoma, it's not in isolation. That's a valuable point, and I think that's where the judgment clinically is important after. So valuable points have been mentioned here.
Yeah. Unfortunately, this patient was lost to follow-up, and she came back a year later. Now her IOPs were higher than previously. She was 20/23 on 1 to 2 classes. Previously, she was 18 and 19. Gonioscopy, again, still closed, but now she developed peripheral anterior synechiae on the left eye, more than 4 clock hours. And then her OCT, RNFL, and the visual fields were worse. So now we categorize her as primary angle closure glaucoma, mild on the right and moderate on the left. Again, her vision was 20/20 with trace nucleosclerotic cataract. These are her anterior segment OCT from a year later. And the next poll was, so what's next? We have a 66-year-old female with mild primary angle closure glaucoma. On the right, moderate on the left. IOPs are 20/23 on 1 to 2 classes.
And I think if I remember correctly, the majority had voted for cataract extraction at this point.
Okay, perfect. So if we end up doing cataract, and this is why angle status is crucial, you know, and like if you had a close angle, will you perform SLT, you know, or if you have open angles, will you remove a cataract in a 20/20 patient? But what if the angles were close, like due to lens rise, you know, will you remove it then? So I think, again, if you are thinking about all these things, it's crucial to have a gonioscopy exam, because it really, the treatment may significantly vary. Now, if the cataract, I'm sorry?
Before you move on, if this patient hadn't been lost to follow-up and we'd just seen them initially after the PIs and been able to do something more for them, let's say they were younger and they had accommodation intact, I think iridoblasty might have been a viable option. It's not anymore at this stage, but it might have been a viable option if they were 20/20 with intact accommodation and primarily plateau. You know, not to be overlooked, that's all.
Perfect, right. So now, yeah, exactly. So now she came back with more damage. We're thinking cataract extraction, okay? So if cataract extraction is performed, will you combine it with any of these procedures? And let's do the left eye, the one that developed goniosynechialysis. Sorry, that developed peripheral anterior synechiae.
So in the poll, and again, I know it was unfair because we didn't have all the information, but majority had voted GSL alone. And then there were about 10% that said maybe endocyclophotoplasty using a plasty technique.
Gotcha. Yeah, sorry guys, that didn't work out. Okay, so just to show you real quickly, this is endocyclophotoplasty, and it was described by our Dr. Varma. And basically, it's the same photocoagulation machine, but basically what you're doing here is that you're aiming the laser on the posterior aspect of the ciliary process. That way, when it shrinks, it brings all the process more posteriorly and trying to open the angle. And again, it's the same as you laser it, you want to blanch those areas.
Maybe I'd just like to elaborate a bit further on that. We do typically say it's almost like a painting technique. So you're kind of going from the tail of the ciliary process and you want to kind of slowly move up. If you do the other way around, you actually risk kind of rotating that process anterior, and you can actually worsen your angle. So that is important. I just don't know if it was very visible to everybody on that video. So I just wanted to make that comment.
I also, I can't take credit for describing this one, I think that was more Ike, and I think he worked with Dominic Podbilski. I've certainly promoted it, but I would have to give that credit to Ike.
Sorry, Ike. Yeah, I read Dr. Varma's paper. Okay, and then we have goniosynechialysis. Basically, what you're trying to do here is that you're trying to separate the iris from the trabecular meshwork. This was nicely performed by Ike. Here we're using the iris micrograspers, and again, you need to be very gentle because you could cause some iridodialysis. You can also use the tip of your cannula. If you have any OBD, you can just go and just gently push down. Now, will you add in this case a trabecular meshwork bypass mix, or wouldn't you not? And this is just, I wanted to open it to the panelists and see what you think in this case is.
So this is a younger lady. She's 66. Her pressures are high on multiple drop classes. She's been lost to follow-up, and she's been closed for a while. She's developed synechia. I'm going to guess she's got some trabecular meshwork dysfunction. So I would probably do phaco with ECP GSL. And yeah, I would totally add a trabecular meshwork mix procedure to try to give her a little bit more runway, because she's got a long life ahead of her.
Yeah, I agree. I think in terms of research, we don't have too much evidence on that yet in terms of MIGS and angle closure cases, but some of it's anecdotal, but we do find that it's been beneficial for us, whether it's better IOP control or in terms of decreasing drop burden.
So it's a really good question, and I think I think probably our group is a bit out there, and I totally agree with Devish and what he said, and Jeb as well. I mean, there's certainly histopathological evidence that chronic apposition, not even PAS, but chronic apposition can lead to ultrastructural changes in the trabecular meshwork, which can be deleterious in terms of control of IOP beyond once the angle is open. So that's one consideration. Certainly, once you have PAS formation, then that risk is higher. And we've all had patients, of course, that have had angle closure. The angle's opened up beautifully, and the pressures are still elevated. Of course, we have to first rule out they don't have persistent angle closure or malignant glaucoma, whatever else, but let's assume they have a deep AC and a nice open angle. Then we call that combined mechanism, right? That's a whole other discussion, perhaps what the definition of combined mechanism is, but in my book, it's when someone's had angle closure for sure, and they've opened up and the pressure is still up. So they have some trabecular meshwork dysfunction, and it could have been, from chronic appositional closure or synechia formation, and that's where the eye stents or some sort of MIGS would be beneficial. And I agree with it. Devish, I'm just curious, we have a lot of MIGS options. People have described stents with it. People have described trabeculotomy with angle closure. Do you have a preference? Do you have access to all of these? Like, which MIGS would you do if you're going to combine MIGS with angle closure like this?
Yeah, so typically I go with iStent, and I can tell you why. I mean, we have awesome choices, but I found the Hydrus is a little bit more challenging to insert than an iStent. It takes a little longer. You have a little more viscoelastic coming out sometimes, at least in my hands. And in an angle closure eye, I want to be in, out fast because I don't want to, get into trouble with malignant glaucoma. So I found the iStent inject, particularly for me, is super, super quick. And you're doing this for a little extra runway. You're not necessarily doing this to be definitive. If you end up with a situation where you can't control the pressure with drops in a combined mechanism situation, I'd come back for a tube later. In terms of goniotomy or procedures like that, I worry a lot about scarring. So now I've induced a trauma in the angle that's going to promote inflammation locally. And I worry that I'm going to get PAS blocking that. So I typically shy away from goniotomy style procedures, Cahook dual blade, things like that. And like I said, for devices, I usually go with whatever is going to be fastest and have the least risk of shallowing in the AC.
I think you said it beautifully, Devish. I agree. I mean, although some of our colleagues have had, pretty good experience apparently with goniotomies and trabeculotomies. So, which surprises me because the biggest challenge in these cases, even with stenting, is I think, as Valentin is going to talk about, is PAS formation that can happen. And so I think that this likely of this happening is increased with trabeculotomy. And maybe Valentin, you may be able to speak a bit about what maybe can be done to prevent PAS, whether you stent or whether you do an otomy technique.
Yeah. So whenever we're thinking about putting a trabecular meshwork bypass mix, such as like eye stents, there are some things that we can do in order to prevent peripheral anterior synechia, because that's what mostly we worried about. So the same ECPL technique that we use for plateau iris, you can actually do a focal ECPL where you just go underneath where you place your mixed device and you just laser those posterior tails in order to open those angles in that area. And also, it's very important to do gonioscopy like the day after, a week after, just to make sure that you're not forming any PAS around the MIGS device. And you can add pilocarpine post-operatively if you need to, if you start thinking that the iris is getting really close to that angle.
So Valentina, if you go into this patient, I mean, do you go into the patients on post-op day one usually?
There's usually corneal edema, so you won't see much.
With Dr. Varma's corneal edema? Come on. I don't think so.
Never.
Yeah, I would agree though. I don't think it's because of corneal edema. It's just that post-op day one, if you see the chambers deep, you're probably not going to do much at that point. And I think it's probably prudent to just avoid manipulation on the cornea if you can. Of course, if there's concern and the pressure is elevated, then it's something to consider if you don't think it's viscoelastic, for example. But the 1 week or the 5 to 7 days is important. And if you started seeing that the angle is closing up, what do you think? What would you say would be going on? What would be your differential diagnosis if you see that the chamber's still okay? It's not like it's like flat or anything, but the angle looks like tighter and you got some synechial formation maybe. What would you be thinking about there, and how would you manage that?
I mean, certainly you have a lot of inflammation, and that could be causing some peripheral anterior synechia. But you mean close angle with PAS?
Well, I mean, usually when you do lensectomy, the angles are pretty good, pretty wide open. Okay, there's some exceptions, but they usually are reasonably open. At the end of the case, certainly they were open for you. And then at post-op day 7, you basically see that they went from a grade 3, but now they look like they're about a grade 1, or maybe there's some synechial formation, for example. What would be in your thought process for what's going on there? Or another panelist can jump in.
I'm thinking more like, posteriorly, if there's anything that's pushing, you can think of malignant glaucoma.
Yeah. So I'd be looking for myopic shift and anterior eye wall position, with lack of sulcus space. If you see it globally, everything is getting narrow. Sometimes you'll get focal PAS that'll just start to reform. An inflamed iris in a post-op period is kind of sticky, and in some cases it'll want to stick back. So it could be that. And so in the absence of global shallowing or anterior eye wall positioning before shallowing occurs, I might be thinking focal PAS, and that'll be the difference between treating it as malignant or treating it with pilocarpine, in my book.
That's a really good important point, Davish, because, certainly the reason why the patient has PAS could be because they have, as Valentina has just alluded to, they have a posterior pushing mechanism, and malignant glaucoma is something that we see higher risk in these angle closure eyes. And so that's something to rule out and be careful of that. Someone mentioned the PI maybe not be patent, and you're right. If they perhaps had pupil block, and then had, an iris Bombay situation, it could. But most of the time, in pseudophakic guys, they don't typically get pupil block unless there's something pushing the lens forward. And that's, again, usually something like malignant. And as we've said, and Devish had a very nice publication a number of years ago with cataract surgery and malignant glaucoma, which happened to be all females, by the way, Devish. That was kind of an interesting finding as well, which correlates to other studies, that these patients can be subtle. It can be very subtle, where basically have a bit of a myopic shift. That's one of the first clues. Patient comes back and says, I can't see as well, and but I can read a bit better. And the chamber's not flat like you think about a classic malignant story in your textbook. It's just subtly maybe, and you can't even notice it unless you did an imaging study. But the angles you can see are more crowded. If you want to use the term narrow, you can. It's not a diagnosis, it's a description, though. When you use the word narrow, there's no such thing as narrow angle glaucoma. That's what I don't like, by the way. I don't like the term narrow angle glaucoma. If you want to say narrow angle, because in your book, it's like a grade 1 or 2 in terms of the Schaefer, that's okay, but it's not a diagnosis. It's basically a clinical finding. And that would imply that there's something posterior pushing. So in that case, you wouldn't want to use pilocarpine, of course, and you want to do something else. But what we're describing here is, of course, that you're not suspecting malignant glaucoma. Still, especially if you have a high iris insertion and a plateau, anatomy, then that can lead to an iris proximity to the angle that's a little too close and can result in synechia. So that's where pilo can be helpful. So I'm glad the panel and the group kind of talked about this, because I think it's not an automatic rush to use pilo.
Yeah, so very good. Now we ended up doing the cataract extraction, as I told you. For the right eye, we did phacoemulsification with intraocular lens placement. We also did endocyclophotoplasty. We did inject eye stents. We did the first generation, and we did 2 of them. And then for the left eye, since the patient also had PAS, we ended up doing goniosynechialysis.
Can you hold up for a second?
Yep. Go back.
No, right here is perfect. So looking at this printout, okay, what stands out to you, first of all? I mean, this is angle closure. What typically axial lens do you see with angle closure usually?
Smaller.
What axial length? Well, give me a number. Like, what would you say typically you see? If you think about an angle closure, what would you expect the axial length to be typically?
I'm thinking like less than 21.
Yeah, yeah. I mean, what is normal? Normal is about 22 and a half or so to 24 or so. So yeah, something like, less than 22 would be something to be worried about. This patient's at 23.5 millimeter. They're right in the middle of an average eye length. So why does patient have angle closure? There's something else on this printout which basically gives away the diagnosis, and perhaps some of the panelists know this. Maybe you know this, Valentina. Maybe you could pick up on it. And Vanessa Vera was Devish's co-fellow, and she just wrote something which was, I think, quite astute, which was anterior chamber depth. And of course, whenever we think about anterior chamber depth, we need to think about it in the context of lens thickness as well, because of course, a very, very fat lens, the average lens thickness of a average cataract age patient is
like 4.75.
Yeah, exactly. Very good. So if the lens thickness was 5.2 millimeters and the patient had a very shallow chamber, well, that explains it. But in this case, what's the lens thickness? It's 4.8, and the AC depth is 2.5. Do we expect an AC depth of 2.5 with a normal lens thickness in the axial lens of 23.5?
No, definitely.
So we have a certain terminology we use for these cases that we use perhaps more internally at Prism. And what do we call this, Valentina?
We call it ram-like eyes. Yes. So relative anterior microphthalmos.
Which I want to be careful, because if you look at the definition, it's not quite like this, but
Exactly.
This is basically a relative
Ram-like
anterior chamber, microphthalmic eye, in the sense that the anterior chamber is relatively more shallow than the axial length as opposed to the anterior segment. And so it's a relative anterior chamber, shallowing compared to an average eye. So this is classic, of course, in someone who has a high iris insertion. Someone who has plateau iris syndrome or configuration is very common in. And what happens is, we also know, and those of us that do sutured lenses, we typically use landmarks like the spur. There's a very good correlation between the zonular plane and the scleral spur, which is again where the iris is inserting there. So in this case, what are we going to be expecting postoperatively with the refraction?
Mm-hmm. To be a little bit more myopic. Ended up a little bit more.
And why is that?
Because of the effective lens positioning. You're positioning more anteriorly.
Correct. And there was some comments on the chat group that says, is it a large lens or high lens rise? Well, I think Devish or Valentina said this as well. I mean, in the imaging previously, it didn't show that the lens rise was that dramatic. So it doesn't look like it's a very big lens. And your lens thickness, if this is accurate, at 4.86 doesn't imply also it's an intumescent lens. So you can still get a high lens rise with an average lens thickness because of the anatomy, but it often happens because you have a very thick lens as well. So this is not that case. This is a good case to demonstrate what you call, which is plateau iris here, and plateau iris syndrome, as the pressure was up in that patient had glaucoma, and also the fact that this patient has probably going to have a myopic result.
Indeed. So for our results, so this patient, 6 months after the surgery, this was what we did, the left eye first and then the right eye. 6 months after the right eye, pressures were 16 and 17 on 0 classes. Her vision was 20/20, but with correction. So we aimed in both eyes for minus 0.15, and she ended up being minus 0.5, as we mentioned before. Like maybe the effective lens position is placed a little bit more anteriorly, and this patient ended up more myopic. And then on the gonioscopy exam, her angles were open. There was no peripheral anterior synechiae. And again, as I said before, you need to be performing gonioscopy regularly on these patients. And then I made like this table, if you have a patient with close angle and you're thinking about doing cataract extraction, then you can think like, okay, is this close angle only due to lens rise? Then you can just proceed with cataract surgery alone. If you think this patient has some lens rise and with a component of plateau iris, then you can add endocyclophotoplasty. If you're seeing some peripheral anterior synechiae, then consider goniosynechialysis. And again, if you have all of the above, you're seeing lens rise, you're seeing peripheral anterior synechiae and plateau iris, such as in the case of the left eye in this patient, then do all of the above, goniosynechialysis and endocyclophotoplasty. And then again, if the pressure is not at target, or patient is on drops, then consider adding a trabecular meshwork bypass MIGS. For take-home points, then I hope I convinced you that gonioscopy is extremely important. Again, if you're planning, you're a comprehensive ophthalmologist, or you're planning on doing MIGS, then really get comfortable with gonioscopy. If you have any imaging devices such as the UBM or anterior segment OCT, then use them, and then you can correlate what you're having. That helps you with the diagnosis. And once you establish the diagnosis, is this open or closed, then you will be able to treat accordingly. As you saw, the treatment does differ. So that's my talk. Thank you for listening.
That was fantastic, Valentina. That was a fantastic review on a quick review on tackling angles, and a lot of pearls. Devish and Jeb, you kind of added so much to the discussion. Maybe we can just finish off the rounds, maybe with just a few comments from the panelists here.
It was a fantastic job, Valentina, and a really, really good discussion. I think we touched on pretty much how to handle almost any situation with angle closure, but also how to interpret, the evidence that's out there. Sometimes we're so beholden to the conclusion of a paper that we forget that we still have to interpret that paper in our real life context. That's the case with angle closure. We're seeing that with COVID-19 too. So I think that was a really, really great sort of philosophical sidebar to the cases.
And I think one thing that we kind of touched upon is the whole issue of GSL. I know you have quite a few opinions about that. Because I think some of the data is a bit controversial in terms of whether or not it's actually beneficial. I think part of the question is also the extent that you're talking about. I think a lot of those papers have some confounding factors which make it difficult to really interpret the results. But I don't know, Ike, maybe you want to kind of discuss that a little bit. I think there are some valid points that you always make, at least with us as your fellows.
Yeah, if you look at the literature in combining goniosynechialysis with phaco, it's a little bit, variable in terms of the results. And I think we summarized it in an editorial in Ophthalmology Glaucoma, George Durr and I, on sort of the summary of the literature. And basically the bottom line is this, that if you do phaco for patients who have who have PAS, then the phaco alone can often release the synechiae, and that may be all you need to do. But if the patient has residual synechiae present, and particularly if it's more than 4 clock hours, that patient potentially is at risk for having persistent elevated pressures despite the phaco being done. So my advice always is that you may not need to do a goniosynechialysis at the time of surgery because the surgery alone will take care of it. Or maybe the patient didn't have PAS that was tough to view perhaps during gonioscopy. But after the phaco is done, the IOL's in, put viscoelastic in there, and take a look with the gonio lens. I think that's really something that the modern day glaucoma specialist and cataract surgeon doing these cases should look in the angle after lens removal and ensure the angle's opened up. Because if it hasn't opened up and there's still residual 4 clock hours or more, that patient's going to be at risk for not having adequate control. So take a look at that, and if they have it, it's going to be helpful to release it, whatever technique we use, whether it's with a spatula or forceps or any other tool. So that's kind of what our summary of editorial was. We put together the evidence. I think we made a pretty good argument for that point, despite the literature stating sort of conflicting results. Some of these are tough, of course, with the methodology on those. So I think those are good points, Jeff. Thanks for mentioning that. I think it's worthwhile to do it. And the other thing too, of course, is that it is very low risk. Although if you pull too hard, you can get bleeding. Done under proper circumstances, it's not a very difficult procedure. It's not a very expensive procedure to do as well. Of course, you need a gonio lens though, and there are many out there that have a single mirror or double mirror, or you can use your MIGS version of Swan Jacob, for example. So it's a good point. Well, that's great. I think we've covered a lot. I just want to mention one more point, in that probably my biggest challenge I have sometime when trainees come in is that they have a patient who has what is called narrow angle, and the pressure may be like 40, but the angle's still not closed, right? And I'd rather use that term than say the angle's open, because I think when people hear the word angle open, they think of like a wide open angle. But an angle opening means an angle is not closed. Right, and that's kind of what Valentina's first slide was, that I kind of try to drill into the fellows, in that if the angle is not closed, then it's not angle closure causing the elevated pressure, And lens removal, while can be effective in open angle, is not necessarily the full answer. So just, be mindful of that. I like to kind of work on the negative in saying when I evaluate a patient with glaucoma, I want to know, is the angle closed or not? And I think you can use the definition, for example, appositional closure or synechial closure for 180 degrees or more, meaning that we cannot visualize, not grade 1 or 2, we cannot visualize the trabecular mesh because the iris is appositionally closed, and use whatever goniotomy techniques that are important to do that, including looking over the hill and using imaging. So that's that point to make. We're kind of really picky on terminology because terminology really dictates the treatment plan in many of these cases. So thank you for sharing that. Valentina, really great job presenting that. I watched the presentation and I'm thinking that if I presented it, I think I probably wouldn't have presented it as clear as you have, because I think you really coming from a learning perspective, which is great. So thank you for doing that. I think it really helped, and the participation from the audience was great. You have some great comments. Devish, you're always an astute observer as an engineer as well, and a colleague and a friend. So thanks for joining us. Hopefully we'll have you back for these as well. Jeb, of course, you've been managing these rounds, so we appreciate that. You're a panelist as well. You presented as well, so thank you. I think we have Jonathan here as well still. And Jonathan, if you read the comments in the chat group, and we had again almost, I think, 750 plus people. The comments were fantastic. These were two great presentations, Anastasia and Paul as well, that added comments. These just continue to get better and better and continue to provide me learning. So for me, it's kind of selfish because I learn from the presenters, and hopefully you have as well. So I will bid good wishes and health to everybody as we close the session. It is Saturday today, right? So we have a lot of things happening at Prism, and we have another set of rounds coming up on Wednesday and then next Saturday. Next Saturday is going to be kind of fun. It's kind of, it's not a sequel to Guardians of the Lens, but it is a different theme where we have a number of international specialists that will come in and have some debates, kind of random debates. We also have other things that are happening. We have a special rounds on May 7th, correct, Jeb, with iStar. It's about new MIGS procedures. And that'll be happening on the Tuesday, if I'm correct, if I'm getting my days right, Jeb. Make sure I'm right on this one.
9 a.m. in the morning.
9 a.m. in the morning, yeah. So it'll be a bit early. And you can, of course, go to the Prism Institute website under webinars and get that information. We update all on that. And then we have a number of other things happening that you'll be seeing shortly in the next few days. So again, for information and updates, visit prisminstitute.com. And hopefully some of you in the future that visit Toronto can come in and visit us when we get over this difficult situation. So thank you again. Thanks to all the panelists. It's been great to see everybody. We'll see you again soon. Those of you who are going to tune in later on in Brazil, we have a session on glaucoma with my friend Alberto, and I'm sure we'll see some of you there. So thank you very much, everybody. Have a great day.
Thank you. Bye, everyone.
Thank you.